All right, welcome back, folks. We're going to conclude our day and learn a lot about naloxone distribution across our state for our perinatal population, and then get into the weeds about how we actually administer it. So it's really my pleasure to welcome our speakers today. We have Dr. Kaylin Klie, who is a family medicine and addiction medicine physician here at the University of Colorado and Denver Health. Her clinical focus is perinatal addiction, which includes the care of families impacted by substance use. She's also the program director of the Addiction Medicine Fellowship here at the University of Colorado, and she serves on various local, regional, and national committees dedicated to serving pregnant and parenting people with substance use. We have Don Stader here as well. Dr. Don is a board-certified emergency and addiction medicine physician, opioid expert, film producer, and social entrepreneur. Don works as an emergency physician at Swedish Medical Center and in the ED and addiction medicine clinic for Lincoln Community Hospital in Hugo, Colorado. He's the founder and executive director of the Naloxone Project, one of the most ambitious national efforts to engage hospitals and clinicians in opioid overdose risk recognition, education, and naloxone dispensing. Rachel Duncan, I believe, is joining us remotely. Is that still the case, Rachel? She is a pharmacist and consultant for the state. Oh, yes. And consultant for Stader Opioid Consultants based in Colorado. She spent the past 7 years focused on policy, advocacy, and educational work surrounding opioid stewardship and treatment at both the state and national levels. And we also have Prescilla Wells here, who is coach and harm reduction specialist at Hard Beauty. So thank you so much. I'll hand it over to you.
I'll just have you know that Kaylin's mocking me as I stand up here, calling me Dr. Don. Yeah. Well, it's our pleasure to be here. It really is about such people doing such amazing work. And today has been really inspirational just hearing all the amazing work going on in our state and how we're leading in so many different realms. One of those, which we're very, very proud of, is a lot of the work that we're doing around harm reduction and making sure that we make harm reduction and evidence-based practices standard of care in many of our birthing hospitals across the state. And one of the ways that we're doing that is through our MOMS initiative, which means Maternal Overdose Matters. As we learned earlier today, overdose is a leading cause of death in pregnant persons here in Colorado and across the country. It's also a leading cause of death of most of our young people, our adolescents, our people under the age of 5. Overdose is the leading cause of death in people under the age of 45. As people who care for a generally younger population, I think then it's incumbent on us to figure out how to address this significant medical need and how to decrease these deaths. And we actually have tools to do so, which is the naloxone that all of you have been given today. I will go a little deeper into that. We're going to skip over that. And first, when we give these talks, I think that we can talk about why it's important that we carry naloxone, why it's important that we empower patients to carry naloxone. But beyond my kind of just saying, hey, this is important, we often try to connect it to a story, a real life story of how naloxone has touched someone and saved someone. So I'm going to transition over to Prescilla, who is going to give us our connection and purpose.
And thank you all. I'm really excited to be here and share my story with you. It's a bit heavy, but I'll take you to where it started. I got pregnant with my 4th child in 2019, and I was trying to be in recovery, but not quite there. I was on a MAT treatment called Suboxone, and I was seeking prenatal care, trying to do all I could to take care of myself, even though I found myself in this situation. I didn't want to use. I prayed not to use, but I just couldn't stop. I couldn't control myself. And, my prenatal care provider was very understanding, and they actually made time for me to sit down with a nurse and plan my birth and plan what my daughter's aftercare would look like and what it really meant to have a baby born addicted to a substance and what type of care would she need and how I can provide that care. I do want to note that before I had gotten pregnant with Anna, I did lose custody of my children due to my substance use. Luckily, I got them home. But I was really grateful to have Anna and have a care provider really sit and listen to me and then help me actively plan how to care for my child that I so desperately wanted and needed to figure out. And they didn't call CPS on me. That was a really active, real fear for me. It was that they would call CPS. And instead, they sat next to me, explained to me how I can care for my daughter, what it would look like after she was born, what would the withdrawals look like, and obviously explaining her 5-day stay in the NICU. Luckily, when Anna was born, she was not presenting signs of being sick. So we got extremely lucky. She did not stay in the NICU. I actually needed a life-saving surgery to remove my uterus that had fused with my placenta. And of course, going home, I was offered narcotics, even though that I had told them I was in recovery or trying to be. And I think the only mistake I can think of that they made is they did not send me home with naloxone and give me that education of I could possibly overdose. Fast forward a little bit, Anna's about 10 months old. I went into a full-blown relapse at that point, and she was taken from me from her father, who also used fentanyl. And I fought really hard to try to get her home, but being in active addiction, I just couldn't get there. And I had found out that she overdosed in his care at 10 months old. And if he had been afraid to seek medical help, she wouldn't be here today. Because he took her to the emergency room, she is here. Those doctors fought for her life. They administered naloxone to her and saved her. I only know what happened due to the medical report because I was obviously not there. And she had to have 4 doses of Narcan to bring her back. That's how strong the fentanyl was that was in her system. And when that happened, I feel like the ball was completely dropped on her. Nobody opened a case. Nobody checked on her afterward. They did try to call CPS. They met with her dad and his son's mom, who he was staying with, and they left it at that and let him go home with her. Luckily, she was okay after that, and she's here today. She's about to be 4. So it does have a good ending, but it doesn't always end that way. The gift of naloxone saved my baby, and I don't know what I would have done if that didn't happen. About a week after I got the phone call that Anna had overdosed, I overdosed myself. And luckily, I was with somebody who had Narcan and who knew how to use it. And if it wasn't for that happening, I would not be here today. I would not be doing the things that I get to do today. So it is very important that we educate anybody who will listen, especially moms, about naloxone, put it in their hands and show them how to use it, because who knows what can happen. Even in active addiction, I would have never thought that my baby would have overdosed. And it's a very real possibility. About 3 months after I overdosed, I made the really difficult decision to detox from fentanyl. And that was brutal beyond explanation. But somehow I made through. And I got some really awesome medical care. I am a woman with bipolar type 2, complex PTSD, addiction. So needless to say, there was a lot of moving parts. And I went to a really good clinic, and they helped me get on mat and take it correctly the way I was supposed to. And from there, I was able to get the mental health care that I needed for my bipolar and got a care plan going from there. And all of this had started just by care providers that I had gone to sit there and listen to me and help me plan my care and help me realize I'm a vital piece in planning that care. What I say matters. And it really reflected in the care that I had gotten from these providers. And I think maybe if I would have gotten that just a little bit earlier, I could have spared myself from 10 years of addiction. Maybe I could have cut that down to 5. Either way, I think showing your patient or whoever you're dealing with that you care and just giving that listening ear can make all the difference. Being compassionate with these women make all the difference. And I know it's extremely hard and we have biases, but this could save their lives. This could save their babies' lives. And it just starts by us just listening. Granted, I wish it was easier said than done, but that's what had made a difference for me. And, of course, connection with community, figure out what recovery organizations are in your area that you can potentially connect these people to. Every time that I tried to recover by myself, I fell flat on my face and relapsed every single time. Not until I had a good, strong community around me was I able to be successful in my recovery. And now today I get to go back and help moms. I primarily work with moms and women's, but I'm not, opposed to working with men too. I just, I am that mama. So I work very closely with moms and help provide them that support. And I think that's a huge piece. I think if we can first and foremost try to support them, educate them, we can take care of everything else. Everything else can be figured out and we can work through it one step at a time, like we like to say in recovery. But it starts with that compassion. And yeah, thank you all for being here today and listening. And I'm up for any questions at the end if you're curious. Thank you.
I think I'm going to turn that one off because it'll buzz, right? Prescilla, thank you. I'm so glad you're here. Okay. And I am going to scoot these forward. Oh, there's Anna. There she is. But this is a really important question, right? Like why, this was 4, years ago. This isn't 14. This isn't 24 years ago, right? This is within, especially for those of us who've been getting together in this type of forum for more than the last 4 years, right? Why did Prescilla go home? Why did Anna go home? And her family go home from these opportunities without naloxone. And I think that there's multiple reasons how we could answer that question. But I think that this can be a never event, right? Infant and child exposures to fentanyl and other opioids can be a zero event by helping educate our families. And then definitely overdose death in this pediatric population should be a zero event because we have the antidote. And actually now you have it in your hands too, right? It's naloxone. Okay. So I'm going to scoot forward a little bit. Wow, these are loading a little slow. It's one sentence at a time. Really, I think what you heard, there's nothing that I can say on this slide that's going to be more important than what you heard from Prescilla and what she's living every day, which is how beautiful and robust and possible recovery is. I get the opportunity to take care of a lot of people in their journey with substance use, with recovery. And I think it's so critical to keep elevating and hearing voices of people who've had this experience and are in recovery, right? I think a lot of us, especially in medical training, our image of a person with substance use is crisis mode, right? Like if you've only ever met somebody in the emergency department or on their worst day of their substance use journey, that happens, right? There are definitely some rocky points for a lot of folks, but it's not the whole story. And so please keep that in mind. Please keep Priscilla's beautiful face in mind when you're thinking about, what's the why, right? The why is our actual people who are on their journey, and we get to be a little part of it. But it's not a journey without risk. Right. There is real risk related to opioid, especially opioid use disorder, and increasingly other substances that may be sold as a stimulant like methamphetamine, but are actually just fentanyl, or other substances that contain fentanyl. Okay. Some of the ways that we can combat stigma are doing the things that you're doing today. And some things to ponder, right? So this is for you. You don't have, this is rhetorical, but thinking about your own healthcare system. Are people coming to receive care within your system? Probably the answer is yes, if you're here today. And if and when pregnant and parenting people with substance use seek care in our facilities, could we describe it as non-judgmental, destigmatized whole person care? Right. I think we toss around a lot of words, but I think if we think about actually how our care looks, it can be a really good time of reflection of where some of the gaps are. And I think we've talked about some of those things even today. And then this is something I'll just put forth. I think we've talked about and heard the term mandatory reporter or mandatory reporting a lot today. But my plea would be if we can try to shift our thinking a little bit from mandatory reporting, which feels like somebody's getting in trouble, to mandatory responding. Right? If you, person in front of me, tell me that you're a person with substance use, then my mandate is not to tell on you, right? My mandate is to respond to that information with compassion and action, right? And so just something to start playing within our own minds is, I think I've probably told many of you or talked with many of you about the importance of implementing destigmatizing language. And I think this is another opportunity where our language can really start to shift how we think and how we talk to and about people, especially pregnant and parenting people with substance use disorder. Naloxone, Narcan, Cloxato, right? These are some of the brand names, but naloxone is the name of the generic medicine that reverses opioid overdose. And naloxone can be one of the first steps in that responding. I'm going to skip through this if that's okay, just in the spirit of time. I don't think any of you are unaware of how overdose affects maternal mortality, but I think I'd ask us to take it a step further, right? If Priscilla had died, right? Think about kind of those ripple effects. I'm going to take a minute outside of just that individual statistic, right? It's more than just that person in front of us that we want to keep alive. She has now, in her living, had the chance to impact dozens, hundreds of people's lives, and is there to take care of her cute, incredibly cute kiddos, right? And so it's really important not to just think about maternal mortality as that individual person, but to think about that person and how their web of connection really impacts all of us, right? It starts to really change our community and our society. Okay. Naloxone saves lives. This is no surprise. You heard a story just right now about how administering naloxone for people with opioid use disorder saves lives. For people who are accidentally exposed to opioids saves lives, right? It's pretty miraculous that we have an actual antidote. That's rare in medicine, to have an antidote to a poisoning or an overdose event. Naloxone is available to each and every one of us right now in a pharmacy. All you would have to do is go up to the pharmacist and ask for naloxone and then pay the out-of-pocket cost, usually between $25 and $70, depending on the make and model in the pharmacy, right? And again, we talked about something that's very simple, but that is not easy. Have any of you done that? Have any of you gone to a pharmacist and asked for naloxone? It'll get your heart pounding and your hands sweating, right? There's something very vulnerable about asking somebody for a medicine that you know could save a life, but is laden sometimes with stigmatization, right? I've had this experience several times, and I make my fellows do it. They have to go to 5 pharmacies. They don't have to buy it all, but they have to go to 5 pharmacies and ask the pharmacist at the counter and say, I want to buy naloxone. And I would challenge you, even though you have naloxone in your hands now, to maybe experience what that's like, right? The other piece of this that's really important is that even when we take it a step further and we send a prescription, Colorado Medicaid will cover all forms of naloxone with zero copay. But you have to, again, go up to a person to fill it, right? And so the fill rates for prescriptions of naloxone are not 100%. They're not 50%. They're probably more like 1 to 2%, because again, there's so much stigma and shame related to filling prescriptions that are related to opioids in general, but specifically opioid misuse or opioid use disorder. Our mission, the Colorado Naloxone Project, and Don can talk a little bit more about this since it's his baby, really started with the target being the emergency department.